has their textbook with them?
I have volume 2.
What's that?
I have volume 2, so it's like...
So volume 2 will match up? Because...
Here's volume 2. Chapters 44, 45, 46.
Because in chapter 46 of this one, what we're going to be talking about is really what we have a lot on clinical. Okay, it's talking about osteoarthritis and joints, arthroplasties. So we have that on the one that is 18. There's a little bit of it. I'm going to go a little bit more in depth than that because of what we have, the content in the book. And that'll be the picture. Okay. Okay, care of patients with arthritis and other connective tissue diseases. Okay, when we talk about arthritis, we think that the one thing this is going to affect still going to be mobility and immunity. Okay? These patients are going to be impaired. They're not going to be able to do what they want. And the other issue is comfort. That becomes a big issue because they're in so much pain. So you're getting the same thing, bone, pain, pain, pain. If there's something done with the bone, there's pain. Mobility, osteoarthritis. Let's talk about that. That's the progressive deterioration and loss of articular cartilage and bone in our different joints. Where are the areas that we find that people have trouble with their joints? Hips. A lot of people need hip replacements. Knee replacements. Hands, we can't do a hand replacement, but yes, we can do some therapies, but we can't really do a hand replacement. Sometimes they're doing a little bit of ankle replacement surgeries, but shoulders. Most common is hip, knees, and shoulders. Okay? The thing that we have to keep in mind is, what is our cartilage made of? We have the proteoglycans, collagen, and the chondrocytes. Okay? As this disease progresses, what does it cause? It causes major inflammation. And so it's between the bones, and they're going to lose what? That synovial fluid. They're going to lose all that cushioning. Okay? Along with losing all the cushioning, when the cartilage disintegrates, you're going to hear the crepitus sound. I told you can hear it for air in the chest, but crepitus in the joints that you're going to hear is the secondary joint inflammation, which causes the grating. Have you ever heard of anybody saying that their bones are grating against each other? Yes. Very painful. Very, very painful. And that causes decreased mobility. And when they're not moving, we talked about this before with the spine, what happens to the muscles? They atrophy. Okay? So that's why we need those weight-bearing activities and weight-bearing exercise. Secondary osteoarthritis happens mostly from a joint injury or obesity. Okay? So they can have problems from trauma, the joint disease. The risk for the hip and knee osteoarthritis is increased in professional and amateur athletes. It can lead to years of osteoarthritis after the trauma. Does anybody have a sports injury now that you're thinking, oh, they said you might have problems with that later? It does happen. Yes, it does. Okay, people that are obese have much more problems with the weight bearing on their joints, on their hips and knees. By 2050, they say 40 million people worldwide will be expected to be severely disabled by osteoarthritis. Okay? Osteoarthritis happens more in women over the age of 55 than men. And you find it twice as often in the military population who are younger than 40 years of age. So we think of our military and everything they give to us, they are increased for the osteoarthritis. If you end up working in a VA hospital, you will see a lot of this, and mobility issues are one of their largest things. One thing that we have found is that the older patients with osteoarthritis, they underreport their pain because they don't want to be on pain meds. Pain meds cause constipation. They cause them problems, right? So with that, they're not taking the pain meds. What else are they not doing? They're not moving. They're not doing what they need to, and it'll stop their motion. Okay. I believe thought it was on here. Ooh, there it is. Gout. So go way down there. That's why I said it's organized different in your book. Okay? So gout is a systemic disease in which urate crystals, so this in your book is on page 1003. So the urate crystals deposit in the joints and other body tissues, causing inflammation. Okay? So that causes our joint pain and stiffness. They get very stiff with gout. Where do we typically find gout on a patient? Most common place? In their feet. And what is one of the most common symptoms that what catches their attention? Pain. The pain is so unbearable, they can't keep a sock on, let alone a shoe. You know, the weight of the sheet on their bed is too painful, and they can't handle that. So if you're taking care of a patient in the hospital, doesn't matter if they think their foot's going to get cold or not. They don't even want a sheet on it. But what you're going to see on this patient, it is red and it is angry, very angry, and it'll be heated. You will feel the heat. The issue is with the secondary gout, the hyperuricemia, is the cartilage has been damaged and they no longer have a nerve supply. So the pain is caused by joint and soft tissue involvement and the spasms of the surrounding muscles. So if they've had gout time and time again, it'll come back if they don't watch their uric acid levels. Okay? And then they will get it back again. Let's see here. The other thing that happens is that muscle, like I said, will atrophy around that area. One of the most common places for gout, we talked about the hallux this morning. So if people have bunions, that advances slowly, right, with that joint pain? But that is the most common place. Yeah, without pizza.
Okay, well, I have dessert.
You're all right. Did you make a Texas sheet cake?
Wonderful. Cookies.
Sweet. Thank you. I didn't know that. I ordered
Like
this.
a spot for us, so you're not in the
Why don't we go ahead right on that tray right behind that, or the second shelf maybe? Thank you for bringing cookies. Thank you, Nikki.
You're welcome.
Do you guys know Nikki? This is Nikki Halderan. Okay.
You just missed her. She's taking teaching pharmacology, which you'll get her in 7th semester.
She made friends.
Abby's loves friends. Yes.
She collects friends memorabilia.
Abby does.
Yeah, Abby does.
Yeah, and Nikki will do clinicals at St. Mary's. She was a nurse there at 44th Street. Yep, she's a good gal. So she's one of your new instructors. All right. Let's go on. So that's why I said I'm sorry. I'm jumping a little bit, but we have to. Okay, we're going to talk about the psychosocial aspect of somebody with osteoarthritis. Kind of compared to what we talked about earlier this morning. What does it cause? It causes permanent changes in their lifestyle. So somebody that was, I'll use my brother for instance. My oldest brother, he's 13 years older than myself. He's been retired, loving life. He goes on at least 2 fishing trips a month. Okay? He loves to fish around his retirement job. His retirement job is he mows at a golf course. And their payment is actual pay. And they can do all the golfing they want for free. And then they have access to 9 fishing lakes. This guy only employs retired gentlemen. And he doesn't have any trouble with work compliance or anything. So my brother gets to fish there, or he's taking trips and fishing all the time. But right now he's fishing like crazy because his mobility has decreased enough that he has to have a hip replacement and a knee replacement. Okay? And it's decreased. What do you think happened? That it's unilateral. He had a horrible car accident when he was in his late 20s. Okay? And he was pulled from this. His knee actually was what had caught, but his injury when he was hit with the vehicle, his femur went through and busted out his socket. Okay? And they took him from the vehicle. He was caught, and his knee was caught, and they kind of rebuilt what they could. At that point in time, he was in traction for 3 months in the hospital. You know, so he was a mess. We're thankful he's alive and that type of thing. So, you figure he's, 67 now and enjoying life. But now his mobility, he's having trouble getting in and out of a boat. So he's trying to put off surgery. They try to put off surgery, try to put it off, because then there's no guarantees. Afterwards they say you're going to be better, but they see people that aren't better and they get really scared. So psychologically, what's happening to these people? Their life is changing. My love for fishing, if I can't go fishing anymore, what's there left to life? So we have to make sure that we are helping them understand things they're going to be able to do, things they have to do to be successful with their treatment. Okay, because it causes a lot of depression, anxiety, and role changing. What if they were the breadwinner for the family and they can no longer do their work, their physical labor? Maybe they were a truck driver and they can no longer hook things up because of their shoulder. Can you think of any other jobs that people could no longer do because of a musculoskeletal injury?
Working as a floor nurse.
Bam! Sex nursing right there, working as a floor nurse. What's the number one thing that goes out typically? Back injuries. That's why I was going to try to show that back video before. But back injuries are the number one. So that's why you will have lots of safety and back injuries. Do not try to do it yourself. People are pretty good about not trying to take care of it themselves. The thing where I think this is just instinct, and we don't ever want to cause any harm to our patients. Are we just going to let them fall? So who falls with them, or who grabs them quickly? And that is the majority of ours. So even as much of a pain as it is to put on that gait belt and to be there with them, that protects the patient, number one, and it protects you too, because then you're able to lower them, bring them down. Okay. All right. So things that also may, excuse me, Papa John's, I believe. This. You are where? Okay. We are in the nursing building. Can you put in your GPS? Is it 709?
Elam Hall,
We're in Elif Hall.
directly across from Richardson Auditorium on Duxman.
I'm actually going to hand off my phone to someone else to get better directions. Okay? That knows the campus. Thank you. What was that?
She said, where are you? The address probably does.
Well,
Right. Nobody knows
I
who you
gave them
are.
the address last night, 709 East Dunklin. I'm glad it's Abby's favorite. And I did see that on the list, and that's what made me choose between Papa John's and Domino's. So, sorry about that. All right. Another thing that happens to these people, the pain not just for their quality of life, it can include their sexuality. It may decrease their energy, that they don't even have energy for intercourse, or they might not find a position that's comfortable. They can't move their knees, different things can cause quite a problem. So then it causes problems in marriages. And then that creates chance for divorce or promiscuity type things. Okay, what can we do to determine if they have osteoarthritis? We can aspirate fluid from a joint, and it'll show the difference in the crystals, or the sed rate will go up. Routine x-rays are also helpful, and an MRI will let us know if there's vertebral or knee involvement, so we'll use MRI. Okay, the patient with osteoarthritis is expected to have a pain level that is accepted by the patient. Okay, so yesterday,
You said you didn't have to be there to meet them or what?
yes, and let him carry up though.
Okay,
He's here.
he's here. No, I just guided him. He was over at the library.
Thank you. Where are you? I could just see him. All right, so we talked about their pain. When we're talking about their pain on clinical, we have to ask all these questions, right? And one of them is, what is your pain level now? And what's that second question?
Functional level.
What is your functional level? So they have to determine what is their functional level so that we can get them there. And we can do things for their pain level. We talked about with drug therapies, right? And NSAIDs are to go to first if we can. And then we talked about music therapy, and we talked about aromatherapy. Could be heat. We can use heat or ice, cryotherapy, so heat or ice. So there's several different things that we can do for them. There's also topical things that we can use, and that would be like a lidocaine patches, or you can use, hello, all right, we're going to have you, can we take like maybe this last desk, you think?
Baker, would you mind sharing the service?
Yes, can you do that? I think